All right, guys, welcome to the reproductive system drugs unit. In this unit, this PowerPoint should be pretty brief for you. I think I just have 19 slides here. But what we're going to focus on during this lecture is I'm going to go over the learning objectives for the lecture. Keep in mind that there are many more important topics in your reading this week, so you do need to delve much deeper than the detail that I'm going to go into in this lecture. But this should hopefully at least kind of get you started on some of the important topics that we're going to be talking about this week. So review of the anatomy of the male and female reproductive system. Basically, the female reproductive system is the body parts that help women or people assigned female at birth, or AFAB, have sexual intercourse, reproduce, menstruate. There are external parts as well as internal parts. The external parts include the labia majora, labia minora, clitoris, vaginal opening, hymen, as well as opening to your urethra. The internal parts include the vagina, the cervix, the uterus, the ovaries, and the fallopian tubes. The male reproductive system then includes a group of organs that make up the reproductive system and urinary system in men and people assigned male at birth, or AMAB. The external parts of this system consist of the penis, the testicles, the epididymitis, and the internal parts consist of the vas deferens, the ejaculatory ducts, the urethra, the seminal vesicles, prostate gland, and the Cowper glands, which are located just below the prostate. So that's just kind of a quick refresh on anatomy. Next, we'll just review the WHO eligibility criteria for contraceptive use. But instead of doing this, there is a WHO contraceptive tool app that is available, but it's not available to everyone. So you could certainly try to download that. But what our book discusses is actually the US medical eligibility criteria, which is also known as the US MEC for contraceptive use charts. I'm going to show you those on the next few slides. Most of the information between the WHO and the US charts is pretty compatible, but it's just a matter of which resource you want to use and how user-friendly will it be for you. The WHO app that I mentioned there, I think it's an older version and it just doesn't work on all devices. But our book does reference this US medical eligibility chart. So here's what that is. Here's what that looks like. You may need to zoom in on this slide, but you can certainly see, you can certainly use Google just to look up this chart as well and get a bigger picture of it, perhaps for your screen. You'll see that these are eligibility criteria that are based on specific conditions that women may have. On the left-hand side, you're going to see the condition. And on the right-hand side, you will see the numbers 1, 2, 3, or 4. These are categorized in various shades of red or green. On number 1, you'll see at the bottom left there, tells you that there are no restrictions and that the method can be used. Number 2 shows that the advantages often outweigh the proven risk. Number 3 shows that there are theoretical or proven risk, and they often outweigh the advantages. And 4 is really unacceptable health risk, and so the method should not be used. On the top of the screen, then you will see the different types of contraceptives, to include the copper IUD, the LNG, or levonorgestrel releasing IUDs, the implants, the depot shots, also known as DMPAs. POP stands for progesterone only pill, and CHC stands for the combined hormonal contraceptives. And this could include the ring, the patch, or the pill. So on the next page is the last 2 pages that go along with this to include more conditions, but all of the other information is the same, including how to categorize it. So this is a chart, or these charts I would print off and have with me if you are ever going to be discussing contraceptive use with women, because these are very good charts. All right, so next we had one of the learning objectives was to explain the use of transdermal patch. They mentioned the ortho evera. They mentioned to explain the dosing considerations and pharmacokinetics. So the patch contains the hormones estrogen and progestin. Your skin absorbs the hormones into your bloodstream through the patch. These hormones really prevent ovulation, which is when your ovary releases the egg. And if you don't ovulate, pregnancy can't occur. There's nothing for the sperm to fertilize. So these oh my goodness, these hormones can also help to thicken the cervical mucus, which makes it hard for sperm to swim basically through your cervix and get to your uterus. They thin your uterine lining, so if a fertilized egg does appear, it is less likely to be able to implant. You can place the birth control patch on your arm, your lower back near your buttocks, your abdominal area below your belly button, above your pubic area, your upper back near your shoulder blades. They ask that you don't place the patch near your breast or near any cuts or open areas or any red or damaged skin. And as with anything, you should always read the packaging closely, as certain birth control patches have different instructions on where to place them. But most of the side effects from the contraceptive patch are temporary and they tend to improve after a few months. Some of the most common ones are nausea, irregular bleeding, sore breast, headache. That's really common in the first couple weeks after starting it, but tends to improve over time, and mood changes. And I hope I'm not the only one bothered by this picture, but to me, this demonstrates how discreet this beige colored patch is or can be for light skin tones, but it's not compatible with other skin tones. So I really hope in the near future we address issues like this going forward, because that's certainly doing many people a disservice. All right, the next one was to describe the use of combined hormonal contraceptives and the prevention of ovulation, and discuss the adverse effects of hormonal contraceptives and common side effects. So mechanism of action, let's start with that. It really works by preventing ovulation primarily. Estrogen inhibits follicle stimulating hormone, or FSH, release. And by inhibiting the development of a follicle and progesterone, this also then inhibits luteinizing hormone, or LH. They both also work to make the cervical mucus inhospitable. Some of the benefits. While there's much documentation surrounding the adverse effects, there's also many benefits, to include improved acne, bone mineral density improved, especially in older women, dysmenorrhea decreased, a decreased risk of endometrial, ovarian, and colorectal cancers, and premenstrual discomforts decreased, including premenstrual headaches. Some of the side effects could include altered bleeding patterns like spotting and breakthrough bleeding. They're really common for the first few months of use. Women who smoke have higher rates of unscheduled bleeding. Additionally, if you miss a dose, there's increased risk of spotting and bleeding. Nausea can be common, and it's often related to the estrogen component. Because of this, many providers will tell their women, or tell the women that they use these, to take their pills at bedtime to help offset this risk. Usually these symptoms resolve within a few months. Breast tenderness and increased vaginal discharge are common in the first few months as well. And occasionally there are reports of depression or mood alterations, changes in libido with combined hormonal contraceptives. Although there's no evidence of an overall increased risk of clinical depression in women who use these, it's certainly still something to pay attention to. Additionally, there could be skin changes, to include darkened patches on the face. This is often due to the estrogen stimulation of melanocytes. For most women, these will fade when this is discontinued. However, they may not fade completely. So another thing women should be aware of. Comparing the mechanism of action, indication, efficacy, adverse effects, side effects of progesterone-only injectables to progesterone-only implants. Well, let's just talk about a few. So there's several progesterone-only methods, to include pills, implants, intrauterine devices, and also the injectable methods. They all have a negative feedback effect on the hypothalamic pituitary axis, which suppresses the luteinizing hormone, as well as the follicle stimulating hormone that is necessary for ovulation. They also typically will work by thickening the cervical mucus, thus inhibiting sperm migration. In addition, they produce a thinly developed endometrium, which may work to inhibit implantation. So in regards to our oral contraceptives, this is one that must be taken every day, and missing it by even a few hours creates a risk of unattended pregnancy due to the diminution effect of the cervical mucus effect. The injectables, the depot injection is given in the intramuscular injection every 12 weeks. It is highly effective form of pregnancy prevention. However, some women will not resume ovulation for several months after discontinuing this, and therefore this may not be the choice for them. Weight gain has been reported side effect, as well as some loss of bone density. Implantables, the implant versions are small rods or little capsules that contain progesterone that are inserted under the skin of the upper arm, where they continuously release progestin in circulation. For some, this is a preferred method because it doesn't require daily or even really periodic action on the part of the user, and it's highly effective with a failure rate of about 1 per 1,000 insertions. What I don't have shown in this slide is the intrauterine contraceptives that are progesterone only. These are among the most effective contraceptive methods used today. They are a bit more invasive, but they are a small device that are inserted into the uterus by a trained clinician. Once inserted, the devices do not require daily action, and they provide between 5 and 10 years of effective contraception, depending on the device that's used. However, as with all of them, they are not 100% effective, and I happen to be one of the lucky ones who has proof of this. My youngest daughter was born after the insertion of an IUD. I did have to have surgery after her birth to have the device removed because it had migrated outside of the uterine lining and was floating around in my omentum. Fortunately, neither her nor I suffered any long-term consequences from this. And although I wasn't anticipating another child at the time, she is certainly a welcome addition to the family. So just keeping in mind that none of these are 100% effective, even when they advertise that they're really, really good. Next is describing the use of postpartum contraceptive using the hormonal method. Our book discusses how ideally this is decided upon prior to an infant's birth. However, some women will remain uncertain about what type of contraceptives are available or undecided about their choice during the postpartum period. And reviewing their personal desires as well as risk and benefits, their lifestyle, their cultural norms will certainly all be helpful in helping them to decide. Keep in mind that while breastfeeding can be a highly effective contraceptive option, it's not always reliable, but the lactational amenorrhea method, or LAM, is pretty effective option for about 6 months if the woman is exclusively breastfeeding and all of the required components to this are in place. The postpartum period does present some specific considerations, including lactation and continuation of an increased risk of thromboembolic events. If you look back on the charts of the US MEC for contraceptive use charts, you will see the section on postpartum, and there is also one on breastfeeding. I'm highly recommending the use of this chart for making decisions and supportive clinical reasoning. So again, that may be something you want to print out and laminate and take along with you. Describing the contraindications of oral contraceptives. I guess when thinking about the combined hormone contraceptive pill, some contraindications include hypertension, breast cancer, ischemic heart disease, migraines when they're associated with an aura, endometrial cancer, cirrhosis, hepatocellular adenomas, and malignant hepatoma. Explaining the mechanism of action of oxytocic drugs. You'll find that most of this discussion is in the chapter on labor. Oxytocin is one of the most common and was first discovered in 1909. And 50 years later, biochemists were able to synthesize oxytocin, and ended up winning the Nobel Peace Prize in chemistry for his discovery. Oxytocin or pitocin is a powerful drug that may quickly hyperstimulate the uterus. It's administered via an electronic infusion pump so that you can carefully control the titration of the medication. Keep in mind that oxytocin causes uterine contractions that are enough to induce birth, but is also not effective to ripen the cervix, which of course is a necessary precursor to labor. So consequently, is a good agent to use once the cervix is already favorable. Half-life is around 6 to 10 minutes. And there's other drugs that are listed within our chapters as well, so you'll want to look those ones up as well. Describing the use of progesterone-only hormonal contraceptives, indications, side effects, and adverse effects. Well, some of these we already touched upon, but indications for progesterone-only hormonal contraceptives include the most common to prevent pregnancy. As with most combined oral contraceptives, women may do the quick start for progesterone-only methods at any time as long as they are reasonably certain that they are not pregnant. If there are any doubts, a pregnancy test should certainly be done. There are very few serious adverse effects in women who take progesterone-only hormonal contraceptives, and those that do occur are usually secondary to allergic reactions to progestins. In general, there are some concerns about increased likelihood of ectopic pregnancies should a contraceptive failure occur, and the thickening of the mucus and slowing of the tubal motility associated with this method could, in theory, contribute to a tubal pregnancy. However, because the medications are so effective, the overall rate of ectopic pregnancy in progesterone-only users is not increased above the expected rate of about 2%. However, if a woman who is taking these progesterone-only contraceptives does become pregnant, the likelihood that that pregnancy is ectopic is about 10%. When it comes to side effects, breast tenderness, headaches, changes in vaginal discharge, and other minor side effects could be experienced. Another effect of any progesterone method is that you can develop a thin endometrium, which could lead to irregular and sometimes unpredictable bleeding and amenorrhea. In addition, because the progesterone-only methods lack the estrogen component of the COC pill, ovarian follicular activity is not inhibited as well as ovulation is. Therefore, you can have a follicular cyst on the ovary, but these are usually asymptomatic and often resolve spontaneously. So next, let's compare and contrast the use of emergency contraceptive agents. Emergency contraceptive is a woman's only reliable option for preventing pregnancy after unprotected intercourse. There are two methods, oral medication taken within 72 to 120 hours, or insertion of an IUD. While there isn't any set restrictions on how many times you can use emergency contraceptives, it is best not to use these as routine birth control. I'm going to allow you to go deeper within your textbook to consider the efficacy and effectiveness, as well as who is eligible and what are the contraindications, as well as what are the side effects women may experience. There are a few drug-drug interactions that we should also be aware of, and oftentimes what may guide the choice is honestly availability. So currently, pharmacy availability of emergency contraceptives is not universal, and many healthcare professionals decline to provide these products, citing religious objections. And therefore, these medications may not be available to everyone in all areas. So part of what may make a woman's decision on this may simply be availability. But you'll see a few of the items I have listed up there and some of the important information to know about each. This next chart the next learning objective wanted you to summarize the use of combined oral contraceptives, transdermal patch, as well as common side effects of each. I'm going to take this opportunity to not fill in this chart for you or go through it line by line. I want to show you how simple it is to take your syllabus and an objective from it and make a chart that you can use. In this instance, really all I did was inserted the table that was 3 by 3, and I filled it with the information that was listed in the syllabus or listed as this learning objective. I can then go in the contraceptive chapter and fill in what these are used for, as well as the side effects. And keep in mind that when the book isn't enough or doesn't go into specific enough detail, use other resources, but be sure to cite them and reference them so we know where you're getting your information from. All right, so next up was discuss why women with a known history of thromboembolism should not take combined oral contraceptives. Well, our book, along with many other sources, tell us that the most concerning adverse effects of COCs are related to thromboembolic events, such as myocardial infarction or stroke. These are associated with the estrogen component in these contraceptives. These are also at increased risk for women who smoke. To sum it up, women who have a known risk of thromboembolism should not take combined oral contraceptives. All right, couple more slides, guys. So next up is reviewing the physical barriers such as spermicides and their mechanism of action. Well, these are some of the physical barrier methods, and they can include both male and female condoms, as well as the use of spermicides, diaphragms, sponges, cervical caps. Since most of our focus is on pharmacological contraceptives, I won't go into more details on all of these, but these are options that are available. The spermicides are chemical substances that are intended to inactivate or kill the sperm in the woman's reproductive tract. which would therefore prevent fertilization. Generally, these are used in conjunction with some physical barriers to prevent them from entering the upper reproductive tract. However, they could be used in a film or a cream separately, but it's just not common to do so independently today. All right, reviewing the use of mifepristone, dosing, efficacy, and contraindications for use. So, imifepristone or mifepristone is an antiprogesterone, and it blocks the action of progesterone, which is necessary for maintenance of pregnancy. So to put it simple, this agent will cause the uterine lining to shed, therefore terminating the pregnancy. I do not require you to memorize the dosing. However, it's important to look over this information. Efficacy does range depending on the study that you look at and when this is taken. Contraindications are that it is not intended for an ectopic pregnancy. It should not be used if somebody has an allergy or sensitivity to mifepristone. Should not use it if you have a chronic or a long-term use of corticosteroids or chronic adrenal failure. It should not be used with any coagulopathies or current therapy with anticoagulants. Side effects and adverse effects are listed in your book, but reported side effects include nausea, vomiting, diarrhea, dizziness, headache, fever, chills, cramping. In some cases, the abortion may be incomplete or the uterine bleeding following the abortion may be prolonged, in which case these women will require further interventions. And lastly, I just want to say thanks for listening. Keep in mind that this presentation was really just a very brief snippet of some of the many important chapters you will be covering this week. I do have many chapters that are listed as optional reading, although I wouldn't think of them as optional as much as you can postpone them. In other words, you should certainly read them before the end of this class. However, I will not be testing you on them this week. They're super important things for you to know. We just don't have time to cover everything in that great of detail this week. So these chapters will be independent reading for you, but you can certainly reach out with questions on them along the way also. So you have plenty of required reading this week to keep you busy. Otherwise, take care, happy reading, and reach out with any questions that you have.